Hello and welcome everyone. My name is Inji Skandar from the Marketing Department in iGenomics Middle East. Welcome to our webinar, Advanced Genetic Testing ART, that will be presented today by Farah Farasha, our country manager in iGenomics. She will talk to you about controversies using PGT-A testing. And our presenter, Tamam Khalaf, our genetic counselor in iGenomics. She will discuss with you genetic testing, diagnosis, counseling, and support. We can give it a minute or two so that everyone can join us before we go ahead and begin. While we are waiting, let's give a small brief about our presenters today. Farah Farasha, she's the country manager of iGenomics in Kuwait, Qatar, Iraq, and Lebanon. She has completed her bachelor degree in science from Lebanese University in 2013. She pursues her master degree between France and Lebanon in Lyon University and Lebanese University in 2016. She completed a full training in embryology at Bahishehir University in Turkey in 2018 under the supervision of Dr. Farhat Shingiz. She completed a genetic counseling session. She's certified to do tubing training for IVF centers and real cases, day 3 and day 5 samples, as well as performing PGT-A experiment by NGS. Currently, she's working on a thesis under the supervision of Dr. Andre for her PhD program. Our second presenter is Tamam Khalaf, board member of the Arab Association of Genetic Counselors, AAGC. She's a genetic counselor and clinical counseling specialist currently based in the United Arab Emirates, UAE. She completed a bachelor degree of science with honors from the University of Toronto, then pursued a Master of Science in Genetic and Genomic Counselling at Cardiff University. Currently, Tamam is working as a genetic counselor and clinical counseling specialist at iGenomics UAE. She's also eligible for the Canadian Board of Genetic Counseling accreditation. She offers genetic counseling to patients all over the Middle East in both English and Arabic. Tamam has a particular interest in counseling approaches and providing empathetic non-directive counseling while considering cultural and ethical directives. Additionally, she's passionate about variants of uncertain significance and the prevalence of such variants in the Middle East. Tamam is also dedicated for raising awareness about the need for diversity and inclusion in the field of genetics. Thank you so much, Farah and Tamam. And with that said, I think we have a good number of doctors. So with that said, I will pass it over to Farah.
Thank you, Inji, for the lovely introduction. And I would like first to thank all of the attendees for being today with us. And please allow me first to express my gratitude and the special thanks to Dr. Iman Flayeh. She is the Specialist Obs and Gynae and Master ART PhD in Fertility Treatment and the IVF Reproductive Psychology President of SSITT. In addition to Mr. Nazar Samari, the Senior Embryologist and the IVF Genetic Lab Director for their special effort and help to make this webinar real and to help iGenomics penetrating Iraq market. So attendees, today I'm going to present you a lovely presentation about advanced genetic test and ART. I'm gonna start first with an introduction about iGenomics company, like a snapshot about iGenomics worldwide. So what is iGenomics? iGenomics is a worldwide reference company in genetic services with always science on your side. iGenomics provide advanced genetic services into two main areas, which is genetics for family diseases, diagnostic and precision medicine. This topic will be covered by my colleague Tamam later on in her presentation, and I'll be focusing more on genetics for treating infertility and having a healthy pregnancy. So let's start with a company snapshot. iGenomics is a company with more than 20 years of experience providing genetic services worldwide. We do have around 25 genetic laboratories worldwide, serving more than 80 countries due or through these genetic laboratories. We are talking about a company with more than 500 employees, and we do like diversity in nationalities. So we have 30 nationalities. Always when we are setting up a genetic lab, we are meeting the quality parameter required by each country. So for example, in our headquarters in Spain, Valencia, we have ISO and CLIA, and in our GCC branches, we are meeting CAP accreditation. Every year, we are performing around 160K embryos screened for aneuploidies like PGT-A. More than 16K embryos are diagnosed for single gene disorder every year, so applying PGT-M program. And as well as more than 60K ERA cases are performed every year worldwide. We were doing around 10K West cases performed, but now we are improving. In addition to publishing more than 460 scientific publications in the top magazine published worldwide, like ISHRE, ARSM, and so on. So let me give you like an overview about our expansion geographically where our genetic laboratories are present. So as you can see here that we have a strong presence in Asia and Europe, as well as in USA. And very soon, inshallah, to set up a lab in Iraq. So this is our Spain headquarter branch, which is based in Valencia. You can see here a lot of technology and a lot of employees. This is where the story began. We are a growing family of 500 employees with more than 20% PhD holders or even students. We always focused on scientific researches, definitely under the supervision of our professor, Dr. Carlos Simon. He's a professor at Harvard, Baylor University, and the University of Valencia. Currently, we are doing more than 460 publications in a yearly basis. And these research and development are with collaborating with the most prestigious universities worldwide. So let me give you a brief about Professor Carlos. He's a world-renowned researcher in human reproduction and stem cells. He's a board-certified and professor at the University of Valencia. He's a professor at Stanford University. And he's as well professor at Baylor College, Houston, and Texas. So these are the most important universities that we are collaborating with them in order to achieve publication and scientific publication, like Harvard University, again, Stanford University, Baylor College of Medicine, NIH, and so on. So let's talk about the portfolio of iGenomics. The genetics for treating infertility and having a healthy pregnancy. As you can see here that we do have 4 biggest titles where we are serving tests for infertility service, for diagnosis, for endometrial health, and for the pre and postnatal test. I'm going to talk a little bit about the infertility service, especially baby gender, PGT-A, and the technology. And the rest will be covered by my colleague Tamam. The first topic here, which will be covered, the main advantages of NGS 24 chromosome versus FISH and clinical aneuploidy screening. So the first question will come. Why we need to screen the embryos for chromosomal abnormalities applying PGT-A program? So first of all, because abnormal embryos could not implant or end in a baby with a chromosomopathy. So here I'm gonna give you like an example, talking about a woman with a 38 years old. Since we are talking and covering Iraq market or GCC, so I'm going to give you an example about day 3 biopsy. So imagine that a woman with a 38 years old, where she's having 10 embryos, out of this 10 embryos, 77% from them may be chromosomally abnormal. So in an average of 7 to 8 embryos will be abnormal. So imagine that we are just only implanting these embryos without screening them. And because abnormal embryos increases the risk of miscarriage rate. So here the same example, I'm going to talk about a woman with 38 years old. So she has approximately 35 to 36% of her pregnancy to lead to a miscarriage, and that is due to abnormal embryos. Now my colleague, the embryologist, will say, okay, Farah, morphological criteria can be selective in some cases to do the ET. Well, good morphology not always means good quality. My colleague embryologist, if you can see this 2 blastocysts, definitely you will come to me and you will say it's the fully hatched blastocyst and it's going to be implanted. Let's go to check the genetic material for each embryo and we will see. So this is a blastocyst, a trophoctoderm embryo, where the genetic material is normal. And let's see the second one. It has one abnormality, which is monosomy 12. So good morphology not always mean good quality. So from here, we start putting some indication to start applying PGT-A program for women who's suffering from this indication. First of all, advanced maternal age, like the woman with 35 years old and above, recurrent pregnancy loss with more than 2 miscarriages, repeated implantation failure with more than 2 failed IVF, severe male factor, and here we are targeting those with a sperm count below 5 million, prior pregnancy with a child having a chromosomally abnormal, Down, Klinefelter, so on, good prognosis patient, and single embryo transfer. And our aim was always to improve the implantation rate, to decrease the miscarriage rate, to decrease risk of abnormal offspring, and the time to get pregnant, or the cost efficiency and the emotional burden. So the following question will remain. How many chromosomes are needed to be screened to find a normal embryo? And here is the bottleneck. So let's see here the profile of fish chromosome, or fish and the coverage number of chromosome that we can cover. Starting from the 5 chromosome, which I think is the most profile that usually in the whole GCC are using it. Imagine that only screening 5 chromosome, you are only testing 36% from the whole abnormality of the embryo. So by this number of chromosome, we are ignoring around 64% of the other abnormalities. Jumping into 10 chromosome, we are almost screening half of the abnormalities. 15 chromosome, we are always screening 72%. So only jumping into 24 chromosome, we will not be able to have a clear genetic picture about the embryo. And here we will have the shock. Usually if we are applying 5 chromosome, we are mainly focusing on chromosome 21, 13, 18, and the sexual. But we are forgetting the most common chromosome, which is 22 and 16. And here you can see that they are the most frequent chromosomal abnormality. It's 9% for 22 and 8.5% for chromosome number 16. I'm going to give you another overview about the chromosomal abnormalities in different portfolio. So imagine that we are using fish for sexing purpose. So here we are saying, okay, chromosome 21 and the sexual chromosome, which if you can add both of them, you will just screen 12.3% from the whole abnormalities, while 20% for 5 chromosome and 46% for only 9 chromosome. So here we are ignoring a lot of genetic information, and this can lead to a miscarriage or either no implantation. So let me give you like a business case or a study case from one of the highest IVF clinic in the Middle East, where they usually were applying only 5 chromosomes to be analyzed for their embryos. So imagine by 2017, they were sending us around 483 embryos, 39% were normal, and we are talking here about only 5 chromosomes. and 51 in 2018 were normal. But let's see if we are comparing 5 chromosomes versus 24 chromosomes. You will come to see that 52% of the normal ones, when they are 5 chromosomes normal, were abnormal using 24 chromosomes. So here, if you can just think about it, imagine that a woman with, again, 38 years old, she has 8 embryos, 5 chromosomes, we get 4 normal embryo, 5 chromosome. You have 50% of this 4 normal embryo, 5 chromosome, to be abnormal, having 24 chromosome. So we get to know that more than 1,000 embryos were analyzed. After doing a comparison between 5 chromosome and 24 chromosome using PGT-A, we knew that 50% this lady have lower chance of transferring the proper really normal embryo based on 24 chromosome. So you will not come to know out of this 4 which were completely normal and which were partially normal using only 5 chromosome. And here I'm going to provide you with some of evidence, just providing you with more information using NGS or using 24 chromosome versus fish. So the clinical outcome after analysis of all 24 chromosomes improved pregnancy and implantation rates for different indications to a higher degree than the previously available technology, which is fish. Because always fish can lead you to a very limited number of chromosomes to be analyzed. And I'm going to provide you with more information in the next slide. So which is the best technique for doing pre-implantation genetic testing for aneuploidy screening? Let's see. Let's talk about the era of progressing with the technology evolution starting from 1995 till the date. So 1995, fish was the first technology used to screen the embryos. And all of you knows very well that fish has a lot of limitation. So we can only screen the day 3 biopsy, and the maximum number of chromosomes that can be screened using fish technology is 12 chromosomes. And we will see the complication of applying this technology. After like 7 years, we get to have ACGH, or array comparative genomic hybridization, where we start thinking that we need really to jump into 24 chromosomes and not only being stuck with this 12 chromosome. And the evolution continued to take place for SNP, for qFPCR, until we get a date to start using NGS. And what is NGS? It's next generation sequencing. We didn't just stop and applying NGS just only to have the complete portfolio of the chromosomes for the embryo, but we as iGenomics, and I'm saying here, we start applying or configuring a customized algorithm in order for us to be able to detect mosaics if we are talking about the 5 samples, in addition to mitochondrial DNA. Mitochondrial DNA to give you a priority for the normal embryo, which one to be transferred. And then now you have the non-invasive PGT-A, which you don't need anymore to use biopsies. And it's a simple technique, like you need to do proper validation before starting just getting the full information from the media, from the cultural media. But it needs like a validation, but we are in. We started already with a real clinic worldwide in Spain, and I think in Dubai we started. Hopefully we'll start very soon in Iraq. So as I mentioned to you previously, I'm gonna just give you a brief about fish technology. And I think all of you are expert in Iraq doing the same because it's local service. So fish is always based on the fixation. And imagine that you don't have the proper cell to be analyzed. If I'm telling you proper cell, because definitely at the end of the day, the nucleus, it's the one representing the whole embryo. The nucleus is fixed on the slide. So imagine here that you don't have, imagine here that you don't have the proper cell, like here, like the multinucleated. So it will not lead to a proper diagnosis. It's always based on the fixation skills. It's always part of limited number of chromosomes, and after doing successive hybridization, the nucleus will be damaged. It will be a time consuming for the embryologist. and you will not be able to get the proper data. Imagine that you did overlapping and the result lead to a monosomy while it's normal, so we will not be able to know. Versus that, I'm just going to provide you with another technology, which is tubing. And what does the tubing mean? Tubing is a process of aspiration for a blastomere or even trophoctoderm biopsy through a stripper from a petri dish. Definitely after performing the biopsy, we should wash it like several times just to avoid contamination coming from the OPU procedure, and that need to be done with a washing media specified by iGenomics, which is contained PVP and PBS, and then loading it into a PCR tube, loaded already with a media. So here you will not damage any of the nucleus because you are not doing fixation anymore. You just need to collect this cell, wash it a little bit, and make sure that you put it in the media, and that's it. So in contrast of the FISH technology, let me explain to you a bit about the NGS workflow or the next generation sequencing. So it is like divided in between 4 biggest steps. The first one will be the library preparation, which is based on whole genome amplified data, and the fragmented library construction with ion single-seq kit. And then template preparation, which is basically an ion chef system. And then the capacity of running a sample per run, you can sequence up to 96 embryos using 530 chip. There are multiple types of chip, but this is something too technical. So the maximum number of embryos that you can screen per run is 96 using this kind of chip. And after that, there is like a link, like generation automatically the data between the ion reporter and the data analysis in order to get for you the report done. So let's have like kind of comparison between the FISH technology and NGS according to different parameters, which is the number of chromosomes analyzed. So as we discussed earlier, that FISH can maximum analyze 12 chromosomes, and it might lead to a damage of the nucleus, which will cover only 50% of the aneuploidies. In contrast, NGS can screen up to 24 chromosomes, which will give you 100% overview about the aneuploidy segmental aneuploidies. So in terms of cell preparation, as you can see that it's based on a nucleus fixation, and it needs really specifically a highly trained staff, while in the NGS, you can do cell loading and tubing, and it's very easy for an embryologist. And definitely an embryologist who's doing like, I will say from 2 to 5 operations a day, it will be really very easy for him. So cell processing, as we can just remember that it's hybridization over nucleo, the nucleus quality depended on successful rounds, especially if you want to cover more than a chromosome, nucleus degradation, times consuming, while in the NGS, it's like very targeted step that it can't lead to a damaging in the nucleus. So it's a whole genome amplification, it's a DNA sequencing, and at the end, we will get robust and reliable information. Let's talk about the diagnosis. After doing that, you will be the one, either the geneticist or the embryologist who's doing the whole steps, he will come to know the results. So it's totally subjective. But when it comes to the NGS, using the automated platform and algorithm that has been developed by iGenomics, it will be objective. And NGS will give us a clear picture about the result, rather than analyzing each profile by itself. So let's talk about the biopsies, and let's see. So as you know that FISH, we can use only day 3, a single blastomere. So it's a lower outcome, it's a high mosaicism rate and high embryo trauma. While in the NGS, we can apply both biopsy day 3, which is a single blastomere, and the trophoctoderm biopsy day 5 and day 6, which will give us a better outcome in day 5 and day 6 frozen cycle. You know that in day 5, day 6, we have low mosaicism rate and low embryo trauma. Giving you like just a picture about the fresh and the frozen transfer, how it goes globally and worldwide, and where are we? Like in the GCC, we are still performing fresh transfer. Almost 80% of our ART cycles are performed in fresh transfer. So we are far away from what's going on globally in Spain, in Brazil, in US, Mexico. So globally, now they are in the trend of doing single embryo transfer, but frozen. So they have achieved 100%, but we are still far away, and we should start applying this very soon. Let's give you some evidence. So frozen cycles are generally associated with a better prenatal and birth outcome than fresh cycle, with a lower incidence of ectopic pregnancy, preterm birth, small for gestational age birth, low birth weight, prenatal mortality, placental abortion, and placenta previa. And this is the article that you can access in order to check the whole article. So increase the pregnancy rate in freeze only versus fresh transfers, and overall implantation and ongoing pregnancy rate are higher in the freeze only compared with fresh transfer. As well as freeze and thaw process in freeze only cycles serve as a filter for embryos of poor quality, which may not survive the thaw. So here it will give you also an idea about which is the embryo who's surviving even after thawing and freezing and which are not. It's true that the costs may be higher for freeze-only protocols because of the cryopreservation, laboratory fees, and possible additional medication costs. Also, frozen embryo transfer are most cost-effective than fresh transfer, but it's giving you like a higher percentage for an implantation rate and for a successful pregnancy, which we need to consider. So as I described to you in the table, the previous table, the mosaicism, let's have a look about the rate and the percentage of the mosaicism day 5, 6 versus day 3. So pre-implantation genetic testing for aneuploidy. What technology should you use and what are the differences? Mosaicism rate at day 3 stage of development is to be high as 50%. So imagine that we are just taking the cell to be biopsied for the cell that it's not representing the ploidy status of the embryo. While if we are waiting till day 5, day 6, and getting the biopsy, the mosaicism rate will be approximately 3 to 5%, which is almost decreasing like anything. So it's possible that the cell biopsied and tested during day 3 may not be representative of the ploidy status of the other cells comprising the embryo. That's why we always encourage embryologists and IVF doctor to keep their patient to day 5 to be able to give them the proper data and the proper chance for their patients to be able to have successfully implantation rate. Is there any impact of biopsy applying in day 3 or in day 5, 6? Let's see. So cleavage stage biopsy significantly impairs human embryonic implantation potential, while blastocyst biopsy does not have a randomized and paired clinical trial. This is like an RCT done by Richard T. Scott, and I'm gonna show you the results come, and it will be like a shock. So blastomere biopsy on day 3 of development resulted in a significant reduction in sustained implantation. Only 30% of the biopsied embryos had sustained implantation and ultimately developed into live-born infants versus 50% of unbiopsied controls. So a relative reduction of 39%. This is if we are talking about biopsy day 3. In contrast, sustained implantation rates were equivalent, so 51% versus 54% for biopsied and control blastocyst, which is day 5 biopsy. So as a conclusion, cleavage stage biopsy markedly reduced embryonic reproductive potential. So in contrast, profoctoderm biopsy had no measurable impact and may be used safely when embryo biopsy is integrated. Here I'm going to show you again summary of evidence just to make sure that we need really, once we are screening the embryo, we really need to screen the embryo with the exact number of chromosomes, not only selecting kind of chromosome just to check the sexing or some selected common diseases. So using CGH array or even NGS, which can lead us to a proper screening covering 24 chromosomes, is more effective than FISH for identifying chromosomally normal embryos, which may result in a higher clinical pregnancy rate and implantation rate after embryo transfer. So what is the impact of pre-implantation genetic diagnosis on IVF outcome in implantation failure patient? It's concluded that in IVF patients, use of PGS along with the blastocyst transfer improve the IVF outcome. And I want one day to hear from you, the IVF doctors who are with us, that yes, Farah, we start applying this program and we have a really successful implantation rate. So coming again to our comparison study, just adding below the clinical result about PGT-A versus not applying PGT-A, controversial result in RCT, especially where we are talking about FISH, but talking about NGS improved with PGT-A. So the results has been improved using PGT-A. And now let's see some evidence. Accuracy of FISH versus NGS. So, controversial results, no live birth rate improvement versus lower miscarriage rate. Recurrent implantation failure, no clinical pregnancy improvement. Young IVF couple, no live birth rate improvement. So clinical data was initially reported to be encouraging for optimized pregnancy outcome using FISH. However, a series of prospective trials failed to demonstrate a benefit to use of PGS with FISH and the cleavage stage biopsy. Why? Because as we mentioned previously that FISH have a limited number of chromosomes and it's always based on the nucleus quality. But for using PGS, applying PGT-A NGS program, we are just only screening the 24 chromosome with no harm for the nucleus. What next for the pre-implantation genetic screening? In comparison with NGS, there is a greater risk of false positive or false negative results. For this reason, the FISH method is nowadays considered outdated. And I'm gonna repeat this. For this reason, the FISH method is nowadays considered outdated. So a synopsis of evidence on 24 chromosome pre-implantation genetic testing for aneuploidy screening PGT-A. I'm gonna just give you an overview about the pregnancy rate and the transfer and the implantation rate and the transfer. And this is like a quite technique comparison, either ACGH or NGS, because both can lead to 24 chromosome screening. But while FISH here were only screening 9 chromosomes. So we have two groups of women with more than below 40 years old and women more than 40 years old. As you can see here that we have around, I will say 60% of a pregnancy rate per transfer, while using FISH technique, we have only 42% or 45%. For the women who are above 40 years old, we do have approximately 50% using 24 chromosome of higher pregnancy rate per transfer, while in FISH it will decrease the half. So imagine 20–25%. And I believe that here the indication AMMA is very important, especially that you doctors are receiving like a different patients with different indications. So AMMA is a very important indication to consider, especially when we are talking about embryos, screening, which test to be applied, how many chromosomes to be screened, and so on. And here we are talking about the implantation rate. So below 40 years old using ACGH or even NGS, we have a 50% of implantation rate, while it's almost 40% for FISH, as well as for the women with more than 40 years old, we have around 40% for NGS or ACGH. It decreased the half till 20% applying FISH. So definitely PGT-A 24 chromosome, better reproductive outcome versus 9 chromosome. And here I'm going just to give you another evidence. So the clinical outcome after analysis of all 24 chromosomes improved pregnancy and implantation rates for different indications to a higher degree than the previously available technology, which is FISH, which only have a limited number of chromosomes could be analyzed. So as we can see that it's more effective than FISH to identify the chromosomal normal embryo, which may result in a higher clinical pregnancy rate and implantation rate after doing embryo transfer. And this is the aim of all the IVF doctors while they are applying this program for their patients. So here we are talking about a randomized clinical trial for good prognosis patient single embryo transfer, like day 3 embryos or even day 5 blastocyst. So we have a clinical pregnancy and ongoing pregnancy applying day 5. This is a woman with below 35 years old, first IVF attempt, no previous miscarriage, so she doesn't have that much indication, to consider. But either blastocyst biopsy increases the implantation rate and the live birth outcome. And here it decreased the miscarriage. So the miscarriage rate will be decreased after applying PGT-A 24. And I think my colleague Tamam will be covering like the topic of genetic counseling pre and post. So we can also take the help of Tamam at this point. And it decreased multiple pregnancy with PGT-A because we are here applying single embryo transfer for a blastocyst program and the frozen embryo transfer. So definitely it will decrease the multiple pregnancy. And it will improve sustained implantation with PGT-A. So in vitro fertilization with pre-implantation genetic diagnosis for aneuploidies and advanced maternal age, let's see a randomized control study. This is kind of evidence and the latest RCTs for applying 24 chromosome and AMMA indication, which is advanced maternal age. So here we have two groups. We have patients who applied PGT-A program and patients who didn't apply PGT-A program. You can see here the pregnancy rate per patient. So we are talking almost about the same percentage, 37 and 39. But let's see the miscarriage rate and the delivery rate per transfer and the delivery rate per patient. So see the miscarriage rate is like 2.7% only from those who applied PGT-A, comparing it with the those who didn't apply PGT-A, only randomized IVF trial. So it's almost 39%. Like there is a huge difference between 2.7% and 39%, as well as the delivery rate per transfer. So here it's high, it's like 52% or 53% in comparison with those who didn't apply PGT-A program, which is 24.2%, as well as the delivery rate per patient. So we should consider applying PGT-A specifically when there is an indication. So let's see the conclusion that we get. Just replying the questions that I have just only posted beginning of my presentation. Which is the best technology to be used? How many chromosomes do we need to screen? So the technology will be NGS. How many chromosomes do we need to really screen? 24 chromosomes. Biopsy and transfer strategy. Blastocyst biopsy with a trend towards deferred transfers to include day 5 and day 6 diploid blastocyst. Why? Because we have seen a lot of evidence saying the same. The clinical outcome, the new RCTs with a 24 chromosome analyzed showed increased live birth rates per first attempt, decreased miscarriages and multiple pregnancies, decreased the time to pregnancy and maybe the cost. So imagine that you are repeating the same and the patient is either not getting pregnant or even she's like just, suffering from recurrent miscarriages. Because we are repeating the same, we are not adding anything to the patient, while she's a best candidate to apply 24 chromosome. So that will be decreasing the time to get pregnant and also the cost. So what is the future? We are currently offering Embrace-based, which is the non-invasive PGT-A testing. So nowadays, we don't need biopsy. We just need spent media culture surrounding by the embryo in order for us to know the genetic material for the embryo. But this is need like a proper validation for each IVF center, and there is kind of limitation in terms of using embryoscope and so on. So we will discuss it later on. And thank you all for your attendance, and I hope that the presentation will be helpful for you and fruitful. Thanks a lot. And now I'm going to give the speech to my colleague Tamam, which will be presenting you about genetics. So thanks a lot. Tamam, all yours.
Thank you so much, Farah. And thank you, Angie, for the wonderful introduction. Hello, everyone. Thank you for taking the time to listen to us today. So just before I proceed, Farah, that was a brilliant presentation. If anyone has any questions, please do write them down in the question panel so that we can attend to them at the end of the webinar. So as Angie mentioned, I'm Tamam Khalaf. I'm the clinical counseling specialist or genetic counselor here at iGenomics. And I'm going to talk to you about genetic testing, diagnosis, counseling, and support that can be offered within iGenomics. So to begin, when we discuss genetic testing and diagnosis, we need to know what our genetic makeup is. And I'm sure everyone's aware of this, but I always like to go through a little refresher. So our genes are made up of millions and millions of cells, and these cells contains our DNA and our chromosomes. Exome sequencing, which is one of the main tests we're going to discuss today, is when we read all the genetic material that are present in our cells, in our genes, in order to understand the building blocks that make the proteins and thus the human body. So the genes are made up of a sequence of 4 letters, A, T, G, and C. Our chromosomes contain all our genes, and of course this is something we all know. And each gene is divided into 2 sections called the introns and the exons. And when we talk about whole exome sequencing, then we're only studying the exome, which is the material that becomes to grow the protein. So when we talk about sequencing, we're actually reading the sequence of genes, the sequence of letters in the exome, in order to understand what our genetic material looks like. When we discuss single gene disorders, there's 3 different primary categories: autosomal recessive, X-linked, and autosomal dominant conditions. We have 2 copies of every gene, so autosomal recessive conditions are caused by changes in both copies of the genes, whereas X-linked disorders are related to changes on the X chromosome, and autosomal dominant disorders are caused by changes in only 1 gene copy. So as Farah previously mentioned, we at iGenomics provide services in 2 main areas: genetics for family diseases, diagnosing conditions, and genetics for treating infertility and having a healthy pregnancy. When we talk about these types of genetic tests, we can actually apply them in all life stages: preconception, prenatal, neonatal, and in childhood and adulthood. Now, when we discuss genetic testing to treat infertility and to ensure healthy pregnancy, Farah mentioned the bulk of it, which is PGT-A and the non-invasive PGT-A embrace. However, there are other tests that help us in order to ensure that we have a healthy pregnancy, or that our patients have a healthy pregnancy, should I say. The first is PGT-M. So PGT-M is done when we know that the family has a genetic condition that has been genetically identified or molecularly identified. So they've had genetic testing and they want to eliminate an embryo with this genetic change, whether this is because they had a previous embryo that passed, they had a previous baby that passed away, or they have a family history of this condition. So that's when we would offer PGT-M. Additionally, we have the NACE test, which is the non-invasive prenatal test. This test is done after the 11th week of pregnancy in singleton pregnancies, and it's just a blood test from the mom that tests the cell-free DNA present in the mother's blood. So the fetal cell-free DNA present in the mother's blood. We can do NACE for 5 chromosomes, 18, 13, 21, and the sex chromosomes X and Y. We can do NACE for 24 chromosomes, and we can also do the non-invasive prenatal test for all 24 chromosomes, so the 22 autosomes plus the sex chromosomes X and Y, plus 6 common microdeletions. In addition to the non-invasive prenatal testing, sometimes the endometrium receptivity needs to be analyzed in order to ensure that the embryo being transferred has the highest chance of success. So for this, we offer the endometrial receptivity analysis test, which measures the window of implantation, the most ideal window of implantation for every woman based on the endometrium microbiome. With the ERA test, 2 additional tests can be done in order to detect pathogenic bacteria that cause chronic endometritis, and that's the ALICE test, and the test of EMMA, which studies the endometrial lactobacilli levels in the endometrium. And these 3 tests together, EMMA, ERA, and ALICE, are called the endometrial, and they're done in order to ensure that the implantation has the highest chance of survival and the embryo has the highest chance of survival and implantation. So when we think about genetic testing to diagnose genetic conditions, so now we're going into a field that's a little bit more technical in terms of we want to diagnose genetic conditions. And you might be thinking, well, we're in the IVF sector, how could this really apply to us? Well, if you have a couple who comes in and they tell you they have a family history of a certain condition, it would be time to think about what testing can you offer? Is this something we can do in order to ensure that they don't have another child with this condition, or that they don't have any children at all if it's a family history, that have similar symptoms to other family members? So to do this, there's different genetic testing that can be done. This is done under the umbrella of the Genomic Precision Diagnostics portfolio at iGenomics, where we can look at the full spectrum of diagnostic tests and panels. We can do this looking at chromosomal tests, panels where we're looking at specific conditions and specific specialties. We can do single gene analysis depending on the gene, or we can look at the whole exome. And I'll talk about this in a little bit more details in the coming slides. So for chromosomal testing, we can do different types of chromosomal tests. We can do karyotype, we can do FISH or qFPCR for prenatal tests. We can also do a chromosomal microarray. So if you have a patient with recurrent implantation failures or recurrent miscarriages and they've come to you and they haven't done a karyotype, oftentimes it is the gold standard of testing to ensure that they don't have a balanced translocation that's causing this infertility. Additionally, chromosomal microarray can give us a lot of information if the patients have had multiple implantation failure or recurrent miscarriages. And I should say, and I'm going to get to this at the end of the session, but I do want to point it out now, the support needed in order to know what test to offer in which condition is always going to be given by the genetic counselors and the scientific team. So in addition to the chromosomal test, we can do genetic and genomic tests, which means it's panel testing, single gene sequencing, whole exome sequencing, and targeted variant sequencing. Sorry, targeted variant testing by Sanger sequencing. In addition to that, there's some specialized tests for specific conditions called MLPA and expansion repeats. These tests are only offered for specific conditions simply because this is the most appropriate method of detection for changes in these problems. For example, Duchenne muscular dystrophy, spinal muscular atrophy can only be studied by MLPA or primarily be studied by MLPA, and Fragile X, for example, could only be studied by expansion repeats. So these types of testing and knowing what test to order is supported by the genetic counselor and the scientific team at iGenomics. So let's discuss preconception genetic testing, because this is really one of the most interesting things about the talk today. When we think about our genetic makeup, as I discussed, we all have spelling mistakes, shall we say, or variants that could cause genetic disease. Now, the problem is when we marry someone with this variant in the same gene. So in the Arab population, approximately 92% of Arab individuals carry a genetic variant in a gene that could cause disease. And that averages out to 1 in 2 couples in the Arab world are at risk of having a child affected with a genetic disorder, because we are a chance of carrying a genetic disease. If we marry someone who has that same genetic change or a genetic change in the same gene, then there is a risk of having an affected child. Regarding the risk of genetic disorder in the Middle East, the risk of genetic disorders between consanguineous couples and couples in general is 45%, as compared to the rest of the world, which is around 2 to 3%. And the percentage of couples at risk of having an affected child is approximately 48%. So that's 1 in 2 people who could have an affected child. This is just another representation of the data where we looked at 571 couples, and from this information, we found out that number, that 48% or almost 50% that I discussed previously. So Arab individuals have a 1.5 times more risk than Western population of having genetic variants per person. And this brings us to this main point. Why is this? Why does this happen? Why do Arab populations have such a high risk of having affected children? This is primarily because of consanguinity. And what is consanguinity exactly? Consanguinity is the union between 2 people who are related as second cousins or closer. And the Arab world in general has historically been inclined to this practice with high levels of consanguinity and inbreeding. So if we look at this map over here, we can see that this dark region in the middle, so that MENA region, Middle East and North Africa region, is where the darker the colors are, the more consanguineous the nations are. And so the Middle East and the North African region have the highest percentage of consanguineous marriage. So what are the consequences of consanguineous marriage? We discussed this briefly, but partially it's an increased risk, it's an increased risk of autosomal recessive disorders and having children that have disease due to homozygous mutation, increased risk of complex diseases, which are very difficult to treat, have little research, and introduce significant amount of anxiety and stress to families. Additionally, some genetic disorders due to increased consanguinity and inbreeding are confined to specific villages or tribal groups, which leads to an unusual burden of genetic disease in these communities. Also, congenital and genetic disorders allow the population to be at risk for infant mortality and morbidity. So something to note is that genetic disorders can't be cured. Our genes are what they are. But sometimes they can be prevented. And it's a matter of considering how can we eliminate this risk or how can we prevent this risk for our patients. So we do this, or one of the biggest ways to support preventing this, having a risk of an affected child, is preconception genetic testing through whole exome sequencing. So there's 2 different types of whole exome sequencing we can discuss. We can discuss the screening test and the diagnostic test. For a couple with no family history of condition, but very high consanguinity, with far relatives having some genetic conditions that are unknown, we often recommend a screening test. So this test can be done for healthy couples, it can be done as a preconception test, or it can be done as a premarital test. We would only look at conditions that are autosomal recessive or X-linked, and we would look at pathogenic and likely pathogenic variants. Whole exome sequencing diagnostic testing, on the other hand, is when we have a couple with a family history of a genetic condition. For example, we know that they're both carriers of beta thalassemia. We know that they have a family history of a child affected with a genetic disorder, or the couples themselves had a previously affected child. In this West diagnostic test, we would look at autosomal recessive conditions, autosomal dominant conditions, as well as X-linked conditions, and we would also analyze variants of uncertain significance. And it's important to note that both the West screening and West diagnostic will include an analysis of the copy number variants. So this just means that instead of only reading the data we have, so only reading our genes or recipes, we also look at any additions or duplications or deletions in these genes that could cause disease. This is only done with a minimum of 70% sensitivity, which is why other genetic testing can sometimes be indicated in the same patients. For example, techniques like chromosomal microarray or MLPA. So in addition to the whole exome sequencing, just sequencing the genes, reading all our 24,000 genes, there are 6 complementary tests that are done with iGenomics in order to ensure that we're actually covering everything we need to look at. These conditions include congenital adrenal hyperplasia, spinal muscular atrophy, alpha thalassemia, Fragile X, Duchenne muscular dystrophy, and hemophilia. These tests, along with the 24,000 gene sequencing, are all covered by the whole exome screening. So this is just another representation. Usually the turnaround time is within 25 working days, and we're working to limit that and to minimize that as much as possible. We've got the 2 different types of West, and they both look at the same amount of genes, it's just a different representation of the report that's released in order to understand the findings. So this slide here, I wanted to point it out because I think it's very important to note that in the conditions that are most common in the Middle East are not the conditions that are most common worldwide. And this is something we at iGenomics, and in fact, most testing laboratories should take into account. So if we notice, in European couples, the most common disease is cystic fibrosis, and a little bit lower on the scale, alpha thalassemia and congenital adrenal hyperplasia show up. Whereas if we look at the Middle East, alpha thalassemia and congenital adrenal hyperplasia are the most common conditions we see. Cystic fibrosis is lower on the list. So this is something that's important to know when we're doing screening or when we're trying to understand the genetic makeup of couples, is that we're looking at the genes and the diseases that are actually related to our patient population. We're not just looking for, we're not using a European or a Western outline, shall we say, to analyzing our community's genetic makeup. These are the rest of the 97 most common diseases that were found in 571 Middle Eastern couples. I'm sure we'll be sharing the presentation so you can take a chance to look at them later. So what do we do? When we have couples with reproductive problems, family history or clinical history of a condition, or we have consanguineous couples, we would recommend the whole exome sequencing test. Once we get the whole exome sequencing test, there's 2 options. Either we find a genetic change that could cause disease, in which case we would go ahead with preimplantation genetic testing for monogenic disorders, PGT-M, or we don't find any genetic changes, in which case, if we still suspect that this couple has risk of disease, we can do other testing. If not, then no additional testing is needed. We can go ahead with normal IVF plus PGT-A as Farah described. So this comes to my favorite topic because I am a genetic counselor, genetic counseling and support. Genetic counseling is essential. Genetic counseling should be offered pre-test and post-test for each and every patient, and in order to support the doctor and the patient make an informed decision about their health. Genetic counseling could include risk interpretation and risk assessment, and it could be done on the phone and in person. Counseling at iGenomics can be split into 2 main sections. So we have the counseling support and the educational support. Counseling support can be done for patients. It will include, like I mentioned, a risk assessment. It should be done pre-test and post-test, where we discuss the possible results, implications of testing, limitations of testing, informed choice and informed consent, as well as future recommendations. Educational support is more to support the clinician, where we provide additional information about the methodology, additional information about the technology used, describing the genetic test in significantly more details, indicating and indications and applications of testing, workshops and webinars for the clinic staff, for the doctors regarding specific details about genetic tests and any updates regarding genetic testing, webinars and conferences, as well as online material to support the patient and the doctor in explaining and understanding these genetic tests. So when we talk about explaining genetics, there's many ways to do this. The recipe or book example, as I mentioned, is when we read, when I say we are reading our genetic material. So we're trying to understand that our genes are like a book and they're a book of recipes that contain all the information. This way it's easy for patients to actually absorb this knowledge and understand what we're talking about. We also use diagrams in order to make things easier for the patient to understand. And all of these are available with our genomics genetic counselors to provide the best care and support to the patient. Some essentials discussion we should have with every patient are the implications of testing. What does it mean to do this testing? What will the results tell us? What different results could we get? This is variable depending on the test we're talking about. If there are any incidental findings, and what are the limitations of the test? No test is 100%, and this is something the patients should be counseled about before going ahead with the testing in order to make an informed choice. So as I mentioned, we support physicians in promoting family planning, using the screening tests in order to help patients have a healthy baby. If a patient has a family history or a child that's affected with a genetic condition, we support the physician by reducing the time to obtain a conclusive diagnostic solution. We support the physician in making an accurate diagnosis, as well as a molecular confirmation of a diagnosis. So this part, I want to kind of stress on it a little bit. So if you get a couple that says, we're thalassemia carriers, at that point, the first question we ask is, have you done a genetic test? Because though they might tell you they're thalassemia carriers and their biochemical tests confirm they're thalassemia carriers, genetic testing is essential in order to find out what variant they carry, what spelling mistake they have, so that we can eliminate this variant or spelling mistake during PGT-A. Additionally, we consider prevention as an important tool. So as I mentioned, genetic diseases can't be cured, but can be prevented. So pre-test counseling, the benefits for patients is that they understand the limitations of the test and the possible results, as well as the implications for themselves and other family members. For doctors, it's supporting the doctor in choosing the best test, discussing the limitations of the test and the technology, helping the doctor explain to the patient the test and the potential results. Post-test counseling benefits are ensuring that the patient is educated about the inheritance pattern, implications to the families, and the next steps, supporting the patient, as well as ensuring they understand the results and the implications of the results. Additionally, for doctors, it's supporting the physician in understanding and explaining the results to the patient, supporting the doctor with additional information and resources that they could share with their patient, and supporting the doctor with further tests if necessary. Something I want to point out is that iGenomics, how we offer counseling, is very much up to you. It's your choice whether you want to send us the patient, and following that, we would send a counseling note with full discussion, with full details of what was discussed, what was decided, and what the recommendation is. If you choose to ask us to come in and join you with the patient and describe and have a counseling session while you're present, or if you would like for us to explain it to you as a physician or a clinician, and you explain that to your patient, that choice is yours. We wouldn't approach your patients unless you request it from us. However, we do strongly recommend counseling pre and post-test. This is just an example of the counseling form that we would fill out following counseling consultation. We discussed the patient clinical history, what was discussed in the session under the counseling notes, what was recommended, and if any testing is recommended. We have a local scientific team as well as an international and global scientific team. The local scientific team includes myself, and Sarah, who are genetic counselors. Lova is our scientific director who deals with the whole exome sequencing. And Dr. Ayman Al-Hattab is a clinical geneticist who's our scientific advisory board member. Thank you so much for taking the time. As I mentioned, please feel free to write any questions you have in the question panel.
Thank you so much, Farah and Tamam, for your amazing presentation. I would encourage all attendees to write the questions if they have any in the question panel, and Farah and Tamam will attend it. For now, we have one question. Let me say it to you. The question saying, what are the limitations for non-invasive PGT-A and why it cannot be used instead of embryo biopsy?
Okay, I'll reply this question, Inji. So first of all, EMBRACE is a non-invasive PGT-A where it needs to have a spent media culture surrounding by the embryo. The first limitation is that this test cannot be used for sexing. The second point is we cannot use it for PGT-SR for structural rearrangement or even for PGT-M for single gene disorder. In addition, that the clinic or the IVF clinic need to be validated for different parameters. So at first, we should make sure that the spent media culture is taken like in a proper way. Like the first wash will be until day 4, and then by day 4 you have to change the media, and then you have to wait until day 6, and by day 6 you collect the spent media culture. So the clinic need to be ready to do the freezing and thawing for the embryo on day 6. They need to make sure that the survival rate is okay. They need to make sure that the ET is done on day 6. In addition to the limitation in terms of specificity and sensitivity for the sexual chromosome. So these are the indications for now. So the doctor who asked me this question, so it's first not be used for the sexing, it's only for the aneuploidy screening. Secondly, it cannot be used for PGT-M or PGT-SR. Thirdly, it needs like an extensive training for the IVF centers to be validated and to be able to use this technology based on the embryologist skills. Thank you.
Thank you, Farah. There's another question, when it will be available in Iraq?
So this is based actually on my physical presence to Iraq, which will be very soon, and this is need actually to be like prepare for it in a very carefully way, especially in terms of validating the centers and having the thawing and the freezing, the ET, the doctors, how they would like to proceed, if they are okay to do day 6 ET, the embryologist, is he okay to live their embryos, they have survival rate on day 6. This kind of technicalities need to be discussed in between the embryologist and the IVF clinic in order for us to be okay to start like just offering it in Iraq. So for us, we don't have any problem to offer it. It's on the IVF center, the doctor, the embryologist hand. We are ready.
Thank you, Farah. Dr. Mehtab is thanking you for answering the question of the limitation. Also, Dr. Iman is thanking you for the nice presentation and informative lectures. Dr. Nazar is saying thanks a lot, Farah and Tamam. Please, can you talk about how we can diagnose thalassemia with pregnant women or pre-pregnancy in IVF?
Definitely. So for thalassemia specifically, depends if it was alpha thal or beta thalassemia. Most of the time we would be discussing beta thalassemia, in which case we can offer single gene testing of the HBB gene. But again, this would be worth having a full discussion beforehand to really understand what thalassemia is present. Is it really beta or alpha thalassemia? Is it a different type of hemoglobinopathy? So this would be a discussion to be had with the patients and the IVF doctor. We would offer genetic testing, like I said, for the single gene disorder, we can still offer the whole exome sequencing screening test because that would cover both conditions as well as any other hemoglobinopathies. Usually also just to say that if we do have a patient with this diagnosis, we would have to do the pre-PGT-M, which would take any time between 2 to 9 weeks, depending on the condition.
Thank you, Tamam. Let me see the other questions. Okay, there's a question saying, sorry. We also need Genomics Genetic Lab in Pakistan. Very informative presentation. Thank you so much. Okay, what about thawing after freezing of good blastocyst examined by this technique? The rate of loses embryo after thawing dose is different from the other techniques. This is from Dr. Basma.
Okay, like thawing after freezing of good blastocyst, it doesn't really affect the embryo. So there are like some articles that state that thawing and freezing will not affect the good quality of the blastocyst. It may lead to 2% only damaging of the embryo, but not higher than that. If the doctor is interested, I can share with you some articles. So just leave your email and I'll reach you like just applying you this article through email. So it doesn't really affect if the embryo or the blastocyst is really in a good quality.
Thanks, Farah. There's a question from Dr. Iman. What about the price? Is very important.
That needs to be discussed internally with Dr. Iman.
Thank you, Farah. The cost, please, again. Okay. Okay, and we take the biopsy only from day 5 embryos. This is from Dr. Nazar, Riyadh.
Yes, according to my presentation, Dr. Nizar, the most important thing is just to increase your implantation rate and increase your pregnancy as well as the live birth. So here to apply the best program, as I mentioned earlier in my conclusion, we need just to wait until day 5 to do a blastocyst or trophoctoderm biopsy in order for us first to decrease the mosaicism rate, which will be decreased as 3 to 5%, that's first. Secondly, it will give you an overview about your embryos, the best quality which will be survived till day 5. That's the second point. Thirdly, freezing them and then applying a single embryo transfer will definitely will increase your pregnancy rate. I have shared with you a lot of evidence during my presentation. So yes, applying blastocyst trophoctoderm biopsy, single embryo transfer, PGT-A 24 for the woman who has real indication, and then we will meet after some time to check the implantation rate.
Thank you, Farah. There's another question from Dr. Basma. Usually we applied it in Qatar and Dubai. This is the question.
Sorry, what is the question again?
Usually you applied it in Qatar and Dubai?
Yes, we do apply in Qatar. In Qatar, mainly the IVF protocol is followed as the presentation. So it's trophoctoderm biopsy, that's PGT-A 24, freeze all, and then do the single embryo transfer. Or according to the age of the woman, if it's below 35, I think 2 embryo to be transferred, or if it's more than 35 years old, 3 embryo to be transferred. This is the protocol followed in Qatar, and approximately 80% from IVF market in Qatar. In Dubai, honestly speaking, I'm not sure. I don't know if Tamam has an idea about it.
Most of the time in Dubai, it's also single embryo transfer following PGT-A, and PGT-A usually, depending on the clinical indications, like Farah mentioned in her presentation, very similar to the Qatar market.
Thank you, team. Okay, there's another question from Dr. Mahitab. Can we do embryo biopsy for PGT-A of frozen thawed embryo and rephrase it again?
Yes, it's doable. We prefer to do it like in a fresh cycle, but if you have already frozen embryo and the patient decided later on to do examination for the embryo frozen, it's doable. So she can just thaw the embryo, take the biopsy, send it to us, and then refreeze again the embryo.
And this can be done for both PGT-M and PGT-A if for some reason there was an indication for a monogenic condition.
Perfect. Thank you, Farah and Tamam. Dr. Mai is saying, please, what about thalassemia?
So as I mentioned, for thalassemia, if the couple have a biochemical test that show that they're carriers of thalassemia, then we would offer genetic testing to confirm. Once they do the genetic test, whether it's a single gene test or a panel test or a whole exome sequencing test, and we have the exact genetic change that's causing the thalassemia, then we can offer the couple PGT-M with their embryo transfer, which means we first have to do pre-PGD, which is a process of taking bloods from the couple and the affected child in order to create a probe. Once that probe is ready, that usually takes between 2 to 9 weeks, depending on the condition. With thalassemia, it's usually around 3 or 4 weeks. Once that probe is ready, then the couple would be ready to start simulation and start their cycle.
Thank you, Tamam. In which country it's now available? This is from Dr. Nidal. I think you have attended this.
You are talking about a genomics laboratories where we are operating locally. In GCC, we do have our local presence in Dubai, in Saudi Arabia, and Kuwait. We have in Europe, in Spain, in Italy, we have in UK, we have in Canada, we have USA, a lot of branches, we have in Asia. So if you are talking about GCC mainly, yes, we are in Saudi Arabia and UAE and in Kuwait.
Those are our 3 labs, with Dubai being the primary lab currently. We do offer testing in different countries as well, and this is all over the GCC, Iraq, as we're getting into, Jordan, Lebanon, Qatar, Kuwait, Bahrain, Oman, like all the GCC countries. Even though we don't have a lab presence there at times, we are still available in those areas.
Thank you, Farah. Thank you, Tamam. Thanks for the information. We hope to apply it soon in Iraq. This is Dr. Heba. Dr. Iman is asking, can we apply the genetic test to all patients of IVF?
It depends on which genetic test. Sorry, go ahead, Farah.
If we are talking about PGT-A, and I'm covering this topic, Tamam will be covering the other topic. There is some indication to take into account if we want really to screen the embryos in terms of PGT-A24. Because for us, as I mentioned, the indications are advanced maternal age, recurrent miscarriages, repeated implantation failure, a severe male factor where a sperm count is below 5 million, as well as a family history or either a child with a chromosomopathy. These are the main indications that we look into while applying PGT-A program for the IVF patients. If we are talking about genetics, please, Tamam, go ahead.
Yeah, if we're talking about genetic testing in general, like the screening test, yes, the West screening test can be applied to all patients. But again, counseling is recommended because some patients it would be more indicated than others, depending on the family history, depending on the needs of the couple, their age. So it really is, yes, but it's also a case-by-case basis, I would say. Similar for PGT-A.
Perfect. Thanks, Tamam. Thanks, Farah. Dr. Mehtab is asking when it will be in Pakistan.
So we can discuss this after. We do have a lab we do have affiliates in Pakistan, and I cover counseling for Pakistan as well. So I think if you could just share your email with us, we can get in contact with you and discuss that after.
Perfect. There is one comment. I hope to talk about your company and it's improved by FDA. This is from Dr. Iman. And she's thank you all very much. This is the last comment. Please, if you have any more questions. question, send it. Sorry, Farah, for interrupting you.
No problem. I just wanted to say something, especially for Dr. Iman. We really appreciate your effort and your help. I know how much time you spent to make this event real and to help iGenomics to penetrate Iraq market. We really appreciate this. And we hope to meet very soon personally. We hope to set like a proper mechanism to help Iraq market, to help the doctors to grow together with iGenomics and to try to achieve the success that the success agreed worldwide in Iraq specifically. So thanks a lot, Dr. Iman, and as well as Mr. Nizar. So we really appreciate your effort. And if you are talking about our company, as I mentioned, that in all the laboratories or all the countries, we always meet the quality parameter, whether it's ISO, CLIA, or CAP in each country that we settle allow. So we do have our SOPs, we do have our department for quality control. So you have all the documents, so no worries about this part.
Perfect. Thank you, Farah. She's saying thank you very much for your efforts too. And I think that's the end of our session. Thank you, team, for having us today, and thank you for all the attendees for attending this webinar. And see you next time.
Thank you, Farah and Dr. Iman. It was lovely speaking to everyone.
Thanks, everyone, and thanks for all the attendees.
Thank you. Bye.
Bye-bye.